don't be afraid of the meltdowns. Meltdowns, quote unquote, are quite normal, quite common in autistic spectrum disorder. What are the red flag signs of meltdowns? When you need immediate psychiatric help, when you need a help of a psychologist, or when you need to take the child to an emergency. In ADHD, the core symptom is about inattention. Herein, the child can attend, but the child can be hyperactive, and this repetitive behavior of the child, which we term is as restrictive repetitive behavior, they are sometimes misdiagnosed by us professionals to be a repertoire of ADHD rather than autism. We know that the autistic children have this sort of very core rigid things, this repetitive behavior. Suppose the child is hand flapping, and if someone catches hold of both of the child's hands or upper limbs, it will make the child more anxious. It will make the child throw a tantrum. Let the child hand flap. Let the child hand flap and study. Let the child hand flap and play.
Hello everyone, and welcome back to India Autism Center, your trusted space for powerful insights, deep conversations, and meaningful insights on autism, neurodevelopmental care, and above all, empowerment of families. Autism or mental illness. This is a very relevant question that disturbs most of us. And this lack of clarity, it leads to a lot of stigma and taboo in autism management and care. To help us understand this important topic, we are joined today by our respected expert, Dr. Raju Shinyogi. Yeah. Dr. Raju Shinyogi, he is a distinguished neuropsychiatrist and academician with over decades of experience. So welcome back, Dr. Nyogi.
Thank you. Thank you for including me. Thank you, India Autism Center, for again including me in your podcasts.
Yes, it's a privilege to have you again back at India Autism Center podcast. How are you doing, sir?
Oh, I'm doing fine. And you know that April is the Autism Awareness Month. So I'm much more upbeat, much more talking, much more posting about autism and posting awareness posters in the social media, in my social media handle about autism to spread awareness.
Yes. So with this, Dr. Nyogi, we'll come to a very relevant thing. Autism, is it a disease? Is it a mental illness? Or is it a condition? In a nutshell, how is autism different from a psychiatric illness?
See, the thing is that if you go into the nomenclature of autism or the way we look into the neurodivergent population has changed, and it's changing. It's fast changing. The attitude is changing, the nomenclature is changing, and also the awareness is increasing. Earlier, it would be known as quote unquote autistic spectrum disorder or autistic or childhood autism disorder. Now this nomenclature is being shifted to being a condition rather than a disorder. And there are neurobiological underpinnings, there are developmental underpinnings. So people are born with autism. It's quote unquote a condition with which you are born with, and over time it evolves. And whether you have mild, moderate, or severe autism, there are a array of spectrum of disorders. I mean, the spectral array of I would say symptomatology and different type of behaviors and different type of divergence actually can be seen in the spectrum between mild to severe autism. But the thing is that it's not a quote unquote typical psychiatric disorder. In autism, you cannot find that there is a certain point in life where these things happened. As the baby proceeds, as the baby travel in its sort of life spectrum to being a toddler, to being an adolescent, we see different symptomatology crop in, and also some symptomatology mitigate. In a psychiatric illness, there is a point of start. There can be a trigger, there can be a life trigger, there can be a stressor, there can be a sort of point where you can find that this was the trajectory, and now several symptoms have cropped up. So there is a quote unquote onset, and there is a progression. And the psychiatric disorders can be either episodic, that means they can be of a single episode. There can be multiple episodes which are known as recurrent psychiatric or recurrent episodic psychiatric disorders. Or like schizophrenia, there can be a single hit the symptom starts and then the symptom progress. So typically autism is a condition rather than a disorder. I would prefer to name it as such, being a condition, being a neurodivergent condition rather than quote unquote a psychiatric illness like depression, anxiety, OCD, whatever.
Sir, but still we use the terminology disorder.
Yeah, still we use. I mean, over time, probably in the next 20 years, we won't be using this terminology disorder. But because I don't know, it could be that using the terminology disorder would actually bring in patients to help. Could be. I mean, if you think otherwise, this could be a philosophy. This could be a philosophy in which we would actually term it as disorder, so that the child gets help. The child gets brought to a professional. Though this is a neurodivergent condition rather than a disorder.
So, sir, related to this, we know the medical model, where initially, there was this school of thought among doctors and professionals that autism, it needs to be sorted. Autism is a disease, it is a disorder. Initially, if we say, which needs to be sorted, it needs to be cured, the problem lies with the individual. How far has even, medical field, it has progressed from this viewpoint?
Well, yes, we have done some progress, no doubt about it, but there's a lot to be done. There's a lot of work which needs to be done. First, I would say that we as professionals, we sometimes miss the diagnosis of autism. We as professionals sometimes sort of tend to think that I can cure it. And there are some professionals who still believe that mild autism can be cured. This is a condition, this is not going to go anywhere. The symptoms can be mitigated. The quote unquote, we can quote unquote try to normalize the child, but we cannot make the child sort of normal. The child would be divergent. We need to accept his or her divergence. We need to sort of make a even ground where the child can function and where the child can flourish. And we know there are savants in autism who have flourished in their own field, in their own way. But if you try to mitigate everything, if you try to bend everything, nothing. You hit the wall. You go nowhere.
And it may cause harm to the individual.
Absolutely. We know that the autistic children have this sort of very core rigid things, these repetitive behaviors. If you try to sort of mitigate that behavior by sort of, suppose the child is hand flapping, and if someone catches hold of both of the child's hands or upper limbs, it will make the child more anxious. It will make the child throw a tantrum. Let the child hand flap. Let the child hand flap and study. Let the child hand flap and play. Because these sort of behaviors are quote unquote cannot be quote unquote normalized. It's this sort of behavior gives the child, it's unlike in OCD, where if you reduce the obsession, the repetitive compulsions will come down. But in case of autism, this behavior gives the child a sense of relief, a sense of sort of dealing with the oddities. For that child, the world is odd. We are odd. So it's sort of a quote unquote behavior of the child to deal with the world in which he is trying to fit himself in. But if you sort of try to squeeze him in a box, you are not going to help the child. You are actually going to regress the child. You are going to build up the child's anxiety, and then you are probably going to halt the child's progress even. And sometimes I see parents who actually sort of don't expose their child to the world itself, because quote unquote either they're ashamed, or their child would be called abnormal, quote unquote called pagla, pagal, whatever. For that, they are actually made homebound. They do not sort of travel outside home. They do not go to the parks. That also bends the developmental trajectory. That also makes the life difficult for the child.
Sir, autistic traits can sometimes look like other conditions, though there may be overlapping conditions. But how do we demarcate the symptoms that we see in autism from other psychiatric conditions like a personality disorder or ADHD or any other such condition that has close resemblance to autism?
Okay, usually 3 types of disorder come to my mind. First is the overlap and the demarcation with ADHD, very, very comorbid. The second is the overlap in cases of adult autism overlap with personality disorder, and the third is the overlap with your OCD. So let me take on the ADHD. If you look into the gene pool which are responsible, the deranged or disorders gene pool which are responsible for autism, ADHD and autism share about 60% of the same gene pool. So there is an overlap of the gene pool. The phenomenology or the phenotype is different. Okay, so and ADHD and autism can overlap. There can be comorbid ADHD and autism. But some behaviors in autism are mistaken as ADHD. In ADHD, the core symptom is about inattention. That is a core symptom. Herein, the child can attend, but the child can be hyperactive, and this repetitive behavior of the child, which we term as restrictive repetitive behavior, they are sometimes misdiagnosed by us professionals to be a repertoire of ADHD rather than autism. If the child has some sensory issues, the child will not sit and study. The ADHD child doesn't have a sensory issue. The ADHD child has issues attending. The ADHD child has issues sort of concentrating, issues attending and concentrating, and problem sitting. The autistic child might sit in a corner and study despite doing the RRB, repeated restrictive behavior. But the thing is that we as professionals need to entice those things. In ADHD, the core symptoms are of inattention, hyperactivity. An autistic child is almost never defined. ADHD, there can be defined in a subtype of ADHD, it's known as ODD, oppositional defiant disorder, where defiance is the core behavior. Most of the autistic children are very obedient, not defiant, they don't have conduct problems. So as a clinician, we need to go into the trajectory of the child's development. We need to take care of the history of the child very astutely. We need to give the child some time, and then sort of decipher. If we can't do it in a single sitting, in a single session, we can have different sessions also. We might ask the parents to bring in videos when he's throwing a tantrum, when he's doing something at his home, because everything cannot be watched and done in a sort of controlled clinic environment. Also, the parents need to report them. Parents do not need to Google or sort of now AI has come up, so maybe upload a video in the AI and ask the AI that give me the diagnosis. It's better done in an office of a psychiatrist or a psychologist.
So, sir, do you feel that this coming of AI, ChatGPT, that has also led to a lot of misdiagnosis?
Well, let me tell you, I mean, there are goods and bads also, pros and cons. Recently, my colleague in the US who was teaching, he said that I go to AI whenever I get a class assignment. I go to the AI, I ask the AI, I give him some prompts, and then I get a frame. On that framework, I work and have my notes. Right. So AI is like it's like a tool. It's like a probably revolver.
Right.
If you use it on common people, it would fail. If you use it in a wrong way, it would fail. If you use it on an innocent person, it would fail. And recently, what happened? There has been several AI-driven suicides in the US, and in the US, I'm a member of the American Psychiatric Association, international member and fellow also. So I get the newsletters. In those newsletters, they have categorically written that people who are taking help of AI, please tell them not to. Please exercise caution and ask your patients whether they are taking help of an AI or not, and please restrict them. Because AI is a tool meant to sort of quote unquote echo your sentiments. So if someone is suicidal and writes in themes of suicide, AI will actually echo and give him or her the same information about suicide or about how to commit a suicide. Nowadays, after some sort of this suicides which has happened, AI assisted suicide, which quote unquote is being named in the media. So AI is now modifying itself. The programmers are modifying the AI to quote unquote see where the red flags are, and maybe it would be a matter of time. Maybe in the next 3 or 5 years, AI would modify itself so that at least AI assisted suicides won't happen. Earlier it was Google, now it is Google Gemini, or for that matter any AI. Patient doesn't know, patient don't have a understanding of the medical model, they don't have a training, but whatever their symptoms are, they sort of quote unquote ask AI, write a prompt. Sometimes common people don't know how to write a good AI prompt. For that you need to train yourself. So the AI answers could be very, very much inaccurate. And nowadays if you go to Google Gemini, there's a disclaimer that the AI responses can be misleading. They have given a disclaimer because of the fact that they can be misleading. AI, if someone goes to the AI to search or make it a search engine, they should actually reiterate, they should cross-check with their professionals. AI cannot ever replace any kind of professionals in the world, I think, at least in the medical field.
Right, and that is a very important piece of, message and alert to the people watching there as well. So moving to the next question that is very much frequently asked, even in the professional fraternity as well. Autism has lot of resemblance with obsessive compulsive disorder, like you were telling. So sir, what are the demarcations and where do they overlap, and how to look for a separate diagnosis of OCD when the individual is showing severe symptoms of autism that is overlapping with repetitions?
Okay, first of all, see, in autism or in OCD, we see a repetitive behavior, but the autistic behavior is typically a restrictive repetitive behavior. The behavior is very narrow, and it's a restrictive kind of a behavior. It's repetitive. OCD also we see someone can wash their hands, but someone can sort of order something. Someone can sort of check whether the knobs are locked or not, whether the switches are off or on, etc. So in autism, it gives satisfaction. Doing the repetitive behavior gives satisfaction and comfort to the patient. In OCD, the patient has an obsession. The patient has a thought, oh, my hands are dirty, so I go and wash it to get a bit of a relief. But that OCD, the obsessions are repetitive. These thoughts will come, and after a wash, probably the patient will find or think that the hands are not clean enough and again wash. So OCD is distress driven. Autistic behaviors are sort of comfort driven. This is one thing. The other thing is that in OCD, the patient would have insight that I know that I am doing something wrong. In most cases, in patients with very poor insight OCD, they don't have insight. But in most of the OCD, or at some point in time during their OCD treatment or during their OCD journey, they might find that at least for some point of time that these are absurd, these are not good. They have to do this in order to get relief of their distress. Third is, whenever you see a autistic child, the autistic child will not have any sort of thought behind that behavior, though that thought is sort of quote unquote, the behavior is quote unquote comforting to the child, and it's sometimes also termed as ego-syntonic. In OCD, it's for most of the time is ego dystonic, means you don't want to do it, it gives you some amount of distress, but then you have to do it. So these are the broad sort of, in OCD there is typically a onset, as I said. In autism, these behaviors are since when the child disorders. So if you spend some time with the child, if you sort of ask a good history, if the mother gives a good history of the child, you can decipher. It's not uncommon that OCD and ADHD and autism can be comorbid. There are about 20-25% of the cases in which, especially in cases of adult autism, the patient might develop some OCD or quote unquote OC symptoms. These needs to be diagnosed in a sort of clinical setting. We have questionnaires to sort of decipher which is the autistic part, which is the OCD part, and they have different therapies and drug treatments as well.
Before moving to the next question, please have a look at who we are at India Autism Center.
Imagine a space designed not just to care for individuals with autism, but to empower them. A place where knowledge grows, support flourishes, and possibilities expand. This is India Autism Center. It is built to redefine how we approach autism. Through education, research, and community-driven initiatives, we create an environment where individuals with autism can thrive. Samavesh, our residential campus, is designed for individuals with autism to live, learn, and grow with dignity and independence. It is more than just a place to stay. It is a space to belong. Manan, our training academy, prepares professionals to provide specialized care. Through structured programs, we equip individuals with the skills to support neurodivergent communities with confidence and compassion. Khoj, our research division, is dedicated to advancing our understanding of autism. Through data-driven studies and collaborative research, we work towards shaping the future of neurodiversity.
Coming back, sir. The last question is also very common among parents, which is, at what point do behavioral dysregulation or meltdowns in autism indicate an acute psychiatric emergency requiring urgent medical intervention?
Well, very good question. I think this. I hope that the parents who are dealing with children who have neurodivergent children in their families, they at least look into this portion of the podcast. Very important, very handy. One is that don't be afraid of the meltdowns. Meltdowns, quote unquote, are quite normal, quite common in autistic spectrum disorder children or quote unquote neurodivergent children. In this meltdown, usually there is a trigger. There is a sort of a tantrum complex in which sort of the patients throw some amount of tantrums. And then when you have some, usually patients are taught about how to deal with meltdowns. So when you sort of bring the child out of the environment where the meltdown happened, if you have minimal sort of communication with the child, let the child calm down. So there is a calming down phase. Usually the meltdowns are self-restricted. And usually parents have these ideas about how to deal with the meltdowns and where or in which situation these meltdowns can happen. Now, what are the red flag signs of meltdowns when you need immediate psychiatric help, when you need a help of a psychologist, or when you need to take the child to an emergency? One is that a continued meltdown is happening. It's not being allayed in maybe 7, 8, 9, 10 hours. So that's definitely a red flag. Second, there are certain regressive behaviors. The patient or the child is having regular meltdowns and there is some regression. What the child has been taught, the child actually forgets. The child again is sort of bedwetting, or the child is again sort of passing potty or stool in the pants. So when there is some amount of regressive behavior. When there is an extreme, usually during the meltdowns, the child can hit others or child can hit himself or herself. But when these are of extreme violent nature, you need to take help. You need probably to medicate the child. You need to know the other strategies to cool the child down. When there is a self-harm behavior or the child has committed a self-harm, or maybe the adult neurodivergent has committed a self-harm. When there are certain psychotic symptoms in cases of it's very difficult to decipher in cases of the child, but it's very easy to decipher in when the child has grown up, become an adolescent or a young adult. When there are other symptoms like the child can hear some voices, there can be some hallucinations, child has some delusions of maybe persecution against someone. Okay, if during the meltdowns or the child has a comorbid seizure and the child throws a fit, or the child who had epilepsy is having recurrent and severe meltdowns, because a meltdown can trigger a seizure. So these are the times when you actually need to take the child to a psychiatrist, to an ER, or your family doctor, or your pediatrician, or your general physician, a psychologist, anywhere. Any help would be helpful. And definitely that person, if he or she cannot handle the child, he or she will handle it to a higher up center.
If you feel that this video session, it is insightful, it is really helpful to you, Please do not forget to hit the like button and share this video as much as possible so that awareness is increased. So, sir, you said about personality disorders as well. So, that also has a close resemblance with adult autism. So, can you please come up with the overlap and
Yes.
again the differentiation?
Okay, so whenever a neurodivergent child grows up, becomes adolescent, becomes an adult, and this neurodivergent is quote unquote trying to fit himself or herself in our own world, which is quote unquote odd to that child or that individual. So whenever this neurodevelopment divergent individual grows up, he or she might have a certain pattern of personality, but that we cannot quote unquote term as a personality disorder. What happens that there are 3 or 4 core symptoms which are actually misdiagnosed as being a personality issue. Like, usually we know that the autistic people cannot mix and mingle with people. They have these social restrictions. So, quote unquote, they seem to be a person with a quote unquote schizoid or cluster A type of personality. But that needs to be either enticed and sort of that needs to be seen that whether this is a autistic spectrum trait or a neurodivergent trait versus a schizoid personality or schizoid personality trait or disorder. Just simply by noting that the patient or the person cannot mix with other people doesn't make him or herself to be stamped to be a schizoid, neither a autistic. You need to sit down, you need to know the entire trajectory of the development and then see what has happened. Similarly, with this this rigidity, this perfectionism, sometimes they are also misdiagnosed to be as quote unquote cluster C or maybe OCPD, obsessive compulsive personality disorder. The autistic children or adolescent or the adult can have certain rigidity about certain things. It can be misdiagnosed to be a OCPD trait or a OCPD disorder. But this could be due to the rigidity of being a autistic spectrum child or being a autistic spectrum adult. Third, there can be quote unquote anger episodes, rage episodes, not being able to communicate what the child or the adult wants to the exterior world, and these anger episodes can be quote unquote misdiagnosed to be a cluster B trait or disorder. Sometimes there can be tantrums and there can be self-harm in the tantrums also. They can be misdiagnosed as borderline personality trait or disorder. These anger episodes can be diagnosed or misdiagnosed as impulsive personality disorder in impulsive PD or impulsive personality traits. We need to delve into the history, into the developmental trajectory, run some checklist, observe the child, watch him over maybe 1, 2, 3 months about his behavior and his repertoire of behavior, his diagnosis, and then maybe we can pigeonhole him and diagnose him. Definitely, a quote unquote neurodivergent won't have a quote unquote normal personality. In any case, we are a mix of personalities or personality traits rather than being quote unquote having a normal personality. There's nothing known as a normal personality.
Sir, this discussion, it is very meaningful, and I feel this will be of help to the parents and the individuals, because a lot of confusion about disability, about psychiatric illness, and it leads to a lot of chaos in the family as well as to what actually the individual is going through. Thank you for your insight, sir. It was really very meaningful and enlightening for us.
Thank you, and keep people aware and making these awareness programs. And we know that April is the autism month, is the autism awareness month. So not only April, make every month an autism awareness month. Thank you so much.
Right. To the listeners, if you feel that this video session, it has really added some value, please do not forget to hit the like button, share this video and subscribe to India Autism Center podcast. Please share the right information so that right message and awareness is reached as far as possible. Thank you so much. Until we come with such next insightful video, please have a look at the video that is popping up on your screen. Thank you so much.